أول شيء بدنا منكم وقوف دقيقة صمت على أرواح شهدائنا في غزة وعلى الأحداث اللي بتدور هناك. شكرا يعطيكم العافية. Well, our next speaker for the second session today is Dr. Rima Badr. Professor Dr. Rima Badr, holding a lot of qualifications, and she is a professor and consultant of pediatric fetal cardiology at King Abdulaziz University and the International Medical Center at Jeddah. She is trained in Germany and North America, completing advanced fellowship in fetal and perinatal cardiology at Toronto, Oregon, and South Florida. Doctor, please.
Bismillah ar-Rahman ar-Rahim. I'd like to thank the organizing committee for the kind invitation, Dr. Abir and Dr. Maher. I feel I'm at home always, and I hope the souls of the children who died in Gaza will rest in peace. Today I'm going to give you some basics of the fetal heart, and I know I'm a fetal cardiologist, so a little bit more than a pediatric cardiologist, so we deal a little bit with the perinatal events that can affect the heart. I have no disclosures, and I just want to tell you, because I know I'm talking to a general audience, the congenital heart disease is the most common congenital anomaly found in the human. As Dr. George said, that we always scan for heart problems and brain problems. The heart, I always say to the parents, is the real power behind the survival of the fetus up to 40 weeks of gestation. And also, the size of the heart is very small. So now we're talking about first trimester scanning, and so it's even smaller than small. So we depend a lot on the training and the types of probes and machines that we're using. And we have to do a proper scanning, screening, and then detailed study of the heart. So the idea of this talk is to familiarize obstetricians and maternal fetal specialists and fellows and sonographers why we're scanning the heart and how we're going to scan the heart. The patient will take, for the first time, about 45 minutes for scanning. So I'm going to talk quite a lot, but it is important before you sign off the report that you know what you're scanning and screening for. Now, the optimal time for fetal exam for the anomaly scan, for you, as you know better than me, it's 18 to 22 weeks. Now we're shifting to the 14-week scan or 13-week scan because of the counseling and genetic testing and outcomes. So people for the past 10 to 15 years are shifting to the first trimester echoes and screening. Now, we have to acquire images in the fetal heart 15 to 8 weeks is possible, and then in the first trimester, we always say it's not the end, it's just the first echo, and then you have to do another one at 18 to 20. So if I scan at 14 weeks and I say there is a possibility of a hypoplastic left or hypoplastic right, I have to bring the patient again. And from the Islamic point of view, she doesn't want to keep the pregnancy. I bring her before the 19 weeks, so it's up to her. So this is the importance of the first trimester scan and the heart and the aneuploidy. So they all work together. Technical considerations is very important that you have the good machine and you have a proper setup when you do the echo, and you have the proper probe and the proper fetal programs when you do the scanning as well. So it's it's not that you are good or bad. You have to have the proper training, you have to have the proper machine, and you try to know how you're using your machine as well. The technical considerations when you're doing the echo, of course, the probe is very important, the curvilinear or the sector, whatever you're using. And one for anatomy, one for Doppler. But you have to narrow the sector width, increase your frame rate, and use zoom. So these are technical issues that makes your image look better. Now, what is the theoretical advantage of prenatal diagnosis? It's very important for all of us, the developed and developing countries, to really look for prenatal heart scans. Now, for the society, it reduces the unnecessary medical costs, of course, because I'm going to decrease the rate. In Saudi, we're now with the Ministry of Health, I'm trying to run a national program for prenatal screening. Because, you know, in the whole of the Middle East, we don't have any countries doing prenatal scans as part of the health system for free. Not if you're rich, you can do it, but as part of the health system. Israel is the only country that really takes care of the prenatal scans, and because it really saves money for the Ministry of Health. So if you diagnose antenatally, you're going to counsel, you're going to transfer in utero, you're going to transfer the mother with a fetus to a proper hospital, and you're going to also decrease the rate of maternal morbidity and mortality for the unnecessary cesarean sections. In Saudi, we have a higher rate of cesarean sections unnecessarily, and as obstetrician, as you know, once you find heart disease, and I've seen that quite a lot, especially fetal arrhythmias, you try to get the fetus out as soon as possible. And then we have the risk of cesarean, the risk of premature birth, the risk of NICU stay, and all this. We can avoid all that with proper prenatal scanning. And of course, the outcomes is very important. In Saudi, we are trying to work on decreasing the rate of neonatal mortality, decreasing the premature birth. And this is very important. These are national programs that really switches the country from developing to developed. For us as medical professionals, it's very important. It will improve the natural history because as we've seen, if you do an echo at 14 weeks, the picture will change at 18 to 20. The heart is still developing. For example, if I diagnose pulmonary stenosis at 14 weeks, so means that the flow to the pulmonary artery is not going to be as good as it should be. At 20 weeks, the valve could be totally closed, and this will be pulmonary atresia. So when you counsel, you have to make sure that this is a developing fetus and developing heart problem. And it's very interesting because as if you're watching a movie and you want to know what's the outcome. You diagnose pulmonary stenosis now, and then at 20 weeks, it's atresia. And then I see the right ventricle is getting smaller and smaller, so I might be going to hypoplast and so on. And of course, it's very important that you transfer in utero that the patient is stable. The mother can go by car, by taxi. But once the baby is delivered, you need a medevac, you need a lot of money to transfer the baby with congenital heart disease, especially cyanotic heart disease. You need to transfer them to another place, and then you have hypoxia of the brain. And so the baby can have successful congenital heart surgery, but he will not be good at math. He will never finish his school because of the hypoxia. Plus, we know now for sure that in utero, the blood flow to the brain is compromised, especially in cyanotic heart disease. So the baby's heart is affecting the outcome already in utero. So I want to make everything optimal for the baby. Now, fetal indications is very important. Now, I'm working as a fetal cardiologist and a pediatric cardiologist. I didn't get a lot of referrals when I first started about 15 or 14 years ago in Saudi because the obstetricians were not aware of what to refer and how to refer. So we started to spread awareness of the indications of fetal echo. Now, there are maternal, there are fetal, and there are familial indications. So, I mean, honestly, if we follow the indications, you are going to refer every week 3 to 5 cases for MFM, and they will refer afterwards if they feel to the fetal cardiology department. Now, the reason for the commonest referral that we get, and lots of studies, and this is one of the studies when I was at Sick Kids in Toronto, is that abnormal cardiac. So what you get in the referral form is abnormal heart, which is very good. You don't have to write more than that. And I'm asking you, please refer as early as possible. Don't sit on the case and say, okay, next time when she comes, I can see the heart in a better status. Refer, because medically legally you're free if you refer. But if you don't refer, you're going to be part of the outcome, and probably it's not good if we miss cases antenatally. Now, what we do when the fetal heart scan, and there are two levels. One is the scanning, or the major things that any obstetrician or sonographer or a primary care physician has to do, and then there's a detailed scan in the hands of a fetal cardiologist. Now, there's screening and there is also detailed. So the screening is what Dr. George was talking about, but he was also talking about detailed scan with 15 points. Now, what we do is that we try as much as possible to do 2D imaging, and I always say you have to have a proper 2D. I've seen residents or fellows, once they look at the heart, they put the color on immediately. No, you have to have a proper 2D image before you put the color on. So adjust your 4-chamber and try and get a proper 2D, and then you can put the color on. And the color, you have to also look at the Nyquist limit and the flow, and you have to have a taste for the images. You have to look for especially in the heart, you have to get the best images. Now, so we look at the 2D, and then we put the color on, we look at the flow Doppler, and then you look at systolic and diastolic function, simply the squeeze of the heart and relaxation of the heart, and important to look at the rhythm of the fetus. Just want to say this is the book that I co-authored with my mentors, and it's available in Amazon, and it's the only book so far that talks about problem-based medicine in cases of heart disease. So this is 36 chapters, and we're hoping to get the other one out soon. Now, the components, as we said, this is a little bit not easy, but I hope I make it easy for you. So you want to know whether it's right or left, and you want to know whether the fetal position, and you know better than us as cardiologists from that. And then you want the situs. You want to know where the stomach is. Is the stomach the only one on the right, is in the left, or is the stomach is on the right? If the stomach is on the right, is it totalis? Is it inversus totalis or not? You try as much as possible to get the 4-chamber. 4-chamber means 2 atria and 2 ventricles properly delineated. And then you go up a little bit and try and find the outflow tracts, which is the great arteries. And if you can, you do the 3-vessel view, which is the aorta, and then make it 3-vessel trachea if you can, which is the aorta and pulmonary artery and SVC. And then look at the function and rhythm. This is how you start the scanning. You start at the what we call in postnatal subcostal or in the abdominal situs, and then you look at the heart and see where the apex is. This is very important. The side, and then you look at the axis of the heart with its left. Usually the heart is on the left, and the axis towards 0 to 45 to the left. And then you try to head towards the head of the fetus and try and see the outflow tracts. And usually it's easy to see the aorta because it comes easier, and it's rounded. And when you go out, and this is not enough, by the way. You just see that, but you have to do another cut sagittal to see the branching of the aorta. This is where you can make mistakes with the transposition, and you can miss transposition of great arteries with intact septum. And then here, you get the pulmonary artery. As you notice, the pulmonary artery is a little bit bigger than the aorta normally. It's about 1.2 to 1. And so the ratio is very important, and it's a prognostic factor in cases of hypoplasia or coarctation and so on. Now, you do the abdomen, and you try and look at the spine and look at the aorta and the IVC and the stomach. Try and get them all in one image if you can. Now, checklist of upper abdomen, you have to look for the position. As we said, stomach on the left. Always look where the stomach is, always look for the spine, and then look at the liver and the aorta. And then, so IVC, aorta, spine, and stomach in the checklist of the upper abdomen. And then you look at look where the stomach, always, of course, you know, as we said here, you label left and right. And so you see the stomach is on the right. Oh my God. So this is wrong. What is wrong here? So where is the heart? And then you try and look for the aorta and IVC and see the relationship of the two, okay? And so this is situs inversus totalis. We can't say totalis unless you see the rest of the intestines and so on, and other, as you probably know better as an MFM. Now, I'm just going to give you an example of what to look and where to look, and make it simple for the abdomen, and this is very important to see. So this is the soletus. Soletus means everything is, stomach is on the left, and the aorta is where you see it, and the IVC, and then you find a mirror image of this, and this is situs inversus. And then we have something called right isomerism. Isomerism means it's the same. So you have two right atrium or two left atria here. So if you have two right atria and you see the IVC and the aorta be on top of each other, and for the left isomerism, you see them on the side. This is a red herring, because if we see isomeric heart, the surgery is going to be, cardiac surgery is going to be not easy, and this is important in counseling. Now, as we said, the fourth chamber is very important, and we say that the area of the heart has to be 1/3 of the thorax, and this is important before you put the ratio. And this is, of course, if you look here, this is a big heart. It's taking more than 50% of the transthoracic ratio. So this is cardiomegaly. Now, as we said, size and then the position to left is very important. And always you have an L here, so this is towards the left. And the size of the heart here is normal. The one before is what it was big. And then you try as much as possible to get the axis of the heart, because axis can give you a hint to anomalies like corrected transposition of the heart. Position shifting, you know better than me that the heart will be shifted, especially in diaphragmatic hernias. And shifting is not dextrocardia. There's something called shifting that is pushed to the side, but this does not mean that the heart is going to be hypoplastic. Okay, pushing the heart to one side, you cannot see the RV clearly antenatally, does not mean that this is a hypoplastic RV. And we get a lot of referrals of that, and good that we get referrals and we clear. Because if I say the heart is shifted to one side, is different in the counseling if I say the RV is hypoplastic. Okay? Now, as we said, the position is very important, and I always say, to me at least, getting a proper fourth chamber is not easy. So spend time on it, and then try as much as possible to look where the RV and the LV and the apex, and which ventricle is apex forming. So if the LV is apex forming, this is very important, this is normal. Okay, so this one here is dextrovergent, which means it's pushed to the other side. Dextrocardia and dextrovergent are not the same. So the axis, as we said, is towards the left, up to 45. And then we look at that and try and, you see, this is very clear that the heart is transverse. So the axis is pushed by the hernia. Now, we look at the rhythm and contractility, and the shifting and effusion is very important. This is a case that I've seen, and this is a hydrops case. And if you see here, there's hydrops, you know better than me, that fluid in the abdomen and fluid around the heart. Now here, this is like finger-like projections in the LV. So the cause of the hydrops here is the abnormal heart. And this is like a bad heart, so the pump was not working properly. And so we had the pump did not work, so we had, we call it heart failure. So the heart fails to pump the required blood to the rest of the fetus, and then we start to have edema, and we start to have ascites and so on. Now, just going to the fourth chamber view, and so this is the LV and RV. It's not easy, not because as postnatally I can see the heart on the left side and I can ask the child to move right and left. We go morphologically. So we look at the attachment of the valves, and we look at the moderator band in the RV, and we look at the tricuspid valve. So this is offsetting more towards the apex. So this is because of the moderator band and because of this valve going more towards the apex. This is tricuspid, and this is mitral. And the ventricle follows the valve. So this is LV because this is mitral, not vice versa. not because this is LV, this is mitral. No, this is mitral, and that's why this is LV. And you look at the foramen ovale, and this is very important. It's opening towards the left atrium here. Now, just to give you the flavor of the four-chamber view, as we said, we put the 2D and try as much as possible. This is actually four with a little bit of 5 in it. So you look at the septum, you try and get the view, and you see the 2 atria, and you see the descending aorta, and then you put the color on, and you see there is intact interventricular septum here, clearly, very easy, and with power Doppler, you can see it properly. And this is just, I want to give you the flavor of a 3D image of a fetus, and with 3D, you have to do 2D, and then you throw the 3D, and you see it's like a pyramid, and there's depth, and you can see the size of the ventricles, you can see the function, and you can see the AV valve regurgitation, or not. So when you do the ventricles, you say, is it right, and is it left? And do I have a ventricle, which is which? As we said, the right ventricle, there's a moderated band, there's tricuspid valve. And then you look at the size of the ventricle, if it's big or small. And then you look at the dilated, so it could be small, it could be big. It could be on the opposite side when we have ventricular inversion. And we can have only one ventricle instead of 2. So, and then you have to compare the size of the LV and RV. Usually in utero, RV is a little bit bigger because it's the dominant ventricle and than the LV. But if you have a small RV early in gestation, this is worrying. And you have to check.
5 minutes to go.
Okay, I'm finishing up. And then the contractility. And look here, and we say the sternum, and here the size, as we said, this is an apex-forming LV, and this is the RV. This is like a normal heart, and this. And you see where the tricuspid valve, it's not at the same level as the LV. This is offsetting of the tricuspid valve, and this is an RV. Now, a systole and diastole simply means that when it contracts and when it relaxes, so the valve here is closed, this is systole, and the valve here is open, this is diastole. And there's the crux of the heart is very important. I just wanted to show you the foramen ovale, which is very, very important for us because in transposition, we look at the flow. As Dr. George said, that the outcome is improved dramatically with the antenatal diagnosis and transposition of great arteries. And this is because of the direction of flow. And we decide, I'm getting this baby to have septostomy at birth or not. I'm not going to spend a long time on this. This is more or less the same. And I just want to show you this. So this is no RV here, no LV. Oh my God. So this is an easy diagnosis. Easy diagnosis because I don't see 2 ventricles. I see 1 ventricle. So this is like hypoplasia, and there's dilatation. And this is what we see when we see single ventricle. So there's nothing called really single ventricle. It's a single ventricle physiology because the other ventricle is there. So this is a very big ventricle, a very small, and this is the LV, and this is the outflow. And you see the cross-section and the 3D, you see big ventricle and a non-functioning small LV. So this is hypoplastic left heart syndrome. And that has, the outcome is not very good in most of the Middle East countries, and it needs 3 surgeries. Now, this is a common and easy diagnosis of atrioventricular septal defect. What do you mean? Atrioventricular. The interatrial septum is deficient and the ventricular septum is deficient, and there's one common valve. And once you see that, you think of trisomy 21. So you either refer the patient, if she came for echo, refer her for MFM or NIPT or vice versa. So this is what we see here, and this is in 3D. And in 2D, there is a little bit of, you can think that one ventricle is smaller, and this outcome varies because of the of inequality of the ventricles. And here, this is in the 3D, you can see that the ventricle is really a little bit smaller, and so you have to, in counseling, you have to see her back more often. Now, this is another case here. When we see tumors in the LV, and this is very important, all tumors, this is also 3D, and this is rhabdomyoma, which is tumor of the heart, and you see a ball at the outflow tract of the aorta. And so actually baby did well antenatally because there's no obstruction, this is dynamic obstruction, and delivered normally at term, and then they had surgery at 48 hours. And we took pathology, and it's what rhabdomyoma, which is multiple sclerosis complex. So I'm just finishing off, and to repeat again the position, the atrium, 4-chamber outflow tract, and the 3 vessels. I didn't go into 3 vessels because it's a separate talk, but we have to talk about the Doppler and before I finish. So Doppler is very important, and as we said, umbilical artery Doppler, umbilical artery PI, MCA Doppler, MCA PI are very important in assessment, and now we're talking about uterine artery and preeclampsia and the flow. So you have to do Doppler. And also, this is a sinus rhythm. When we do Doppler, we do it for sinus rhythm or arrhythmia. And this is the SVC aorta cut by Dr. Firon, who passed away many years back. And this is AV concordance. So atria ventricle, atria ventricle, atria ventricle. This is a complete ECG antenatally, and this is sinus rhythm. Now, atrial bigeminy, atrial trigeminy, which is two beats and then 1, and then 3 beats and then 1. So this is very important in diagnosis. I want to invite you to join the fetal series that we run every month, webinars under Congenital Heart Academy, Washington, D.C. National Children's Hospital. I run these webinars for the past 3 years. You find 40 echoes with full description of fetal hearts and with world eminent speakers. I really encourage, it's free of charge and very informative, the fetal series on the YouTube. And I'd like to thank you so much for the invitation.
Thank you, Professor Rima, for this rich talk. We have time for 2 questions, so if anybody has something to comment or to ask.
Well, I can ask you.
Yes.
Do you find it easy to do Dopplers on babies? Do you have time to do? Because I've noticed that most obstetricians don't have time to do Doppler. And if they do Dopplers, they think it's extra. Right? In practice, in private practice. I think it's a message is try and do Dopplers because you can diagnose arrhythmias easily. If just by hearing, it will be tat, 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 tat. This is sinus rhythm. If you do this is arrhythmia. Just you should put the Doppler and put the volume on, you will diagnose arrhythmias. And refer.
Thank you very much. Thank you.
Thank you. I'm glad to introduce Professor Ala Al-Ibrashi, who is the Director of Fetal Medicine Unit and a Professor of Obstetrics and Gynecology at Qasr Al-Aini Faculty of Medicine, Cairo. Professor Ala serves as the board member of the Fetus as a Patient Society and the WAPM Educational Committee in Developing Nations, and he's the editor of the Qasr Al-Aini journal. His talk will be about skeletal dysplasias. This is a very interesting subject, and I'm sure we will see nice images now.
Okay.
Professor Ala, the floor is yours. Thank you.
Thank you very much. Can put it, please. Coming to your nice country, as always, I've been here many times. My dear friend, Dr. Maher, thank you very much for the invitation. Dr. Abir, I congratulate you for what you have achieved from the Royal College. This is a very nice thing to have somebody in the lobby of Jordan to have this great achievement. So, congratulations. In the next few minutes, I'm going to present the fetal skeletal dysplasia, which actually is a very tedious topic. Most of the speakers don't like to speak about skeletal dysplasia from its diversity as well as difficult diagnosis. This is what are you going to see when you come to Cairo next November. It's the opening of the Grand Museum. We are going to show you all the treasures of our young youth, Tutankhamun. This is the logo of our university. I belong to Cairo University, and the Cairo University have its slogan is the Tut. Tut is the god of wisdom and the god of reading as well as hieroglyphic. And this is the slogan of our hospital, Qasr Al-Aini Hospital, a very famous, oldest one. The one which is in the same oldness is the American University in Beirut. Both was 1824. So this is Mhotub. Mhotub is the most famous engineer as well as a doctor. He is now the god of medicine for the old Egyptian, and also for all the medicine. It's considered the god. Fetal skeletal dysplasias comes to the very important fact you have to ask yourself, what is the task in fetal anatomy concerning the skeleton? You measure the femur, only the femur. If the femur is matching with the age, then you don't have to measure any other bones. You just have to mention the presence of the other bones, as well as the relation of the leg, including the tibia and fibula, to the foot, and the hand to the radius and ulna. If you do not find it matching, then you have to measure all long bones. And this is another task. So this is the first simple thing. How can we identify the bones? You have to have the learning curve to see all the bones clearly. And in your report, you have to mention all long bones are seen. Normal centile growth of the femur. So this will comprise what is the task of doing fetal skeleton. All these are normal presentations for the how can you see. The most difficult is the upper arm. You have to have the skills to follow up all these. Remember that the legs are usually overlying, so sometimes you have a positional clubbing. This is not a real clubbing. You have to identify the real clubbing. This is how to see the upper arm and to follow to the tibia and fibula, to the radius and ulna, and this is the fingers. We have to see the fingers by the second trimester? According to the ESOG, no. You don't have to see and count the fingers. It's not a part of your routine. However, you should have the experience that if you find any other abnormalities in the limbs or whatever, you have to search for polydactyly or something, especially if you have a familial. This is excellent view at 13 weeks. That's why I'm telling you the importance of 13 weeks. You can see all the segments of the long bones clearly, and you can mention that all long bones are seen, as I'm going to show you in the focal dysplasia. This is as Philippe Genti, my great friend and great loss. He passed away. All your curves are based on Philippe Genti. So some of the definitions that you are going to face, amelia, diastosis, hemimelia, and all these. Some of them you're going to describe it as mesomelic, rhizomelic, according to the short segment, if the short segment is proximal or intermediate or terminal. So let me pass these parts in order to get to the main core of my lecture. If I take any classification of the skeletal dysplasia, nothing will give you the most proper way of classification. And actually, I found out that this classification is the best, which is the generalized skeletal dysplasias and the focal skeletal dysplasias. The generalized are all the limb is micromelic, all the limbs are micromelic, and all of them fall beyond the fourth standard deviation, okay? So it's like very short. You cannot miss it. And small thorax is a predominance because actually small ribs, and this is the cause of death, pulmonary hypoplasia. That's why they are lethal. All of them are lethal except the heterozygous achondroplasia. And the other signs that accompany this type of generalized, it makes it differentiated. I mean, you can discriminate between types through the other presence of other signs. One of them is demineralization. While the focal dysplasia is extremely important, and this is what you are going to miss in your routine exam, the focal dysplasia, as I'm going to show you. Okay. So, if you have like generalized skeletal dysplasia, you have to be sure that the ribs are very short. Normal ribs will cover half of the thorax, so it's much less. The thoracic circumference is 0.5, 0.6, usually between 0.7, 0.8. So this is very characteristic, okay? The cranium ossification depends on the mineralization. That's what I'm going to describe, as well as the fetal spine. So look at this one. This is a type of generalized skeletal dysplasia. extremely micromelia with the depression at the thorax in order to show you the thoracic dysplasia. And also, you can notice very clearly here that the spine is even not seen because of the demineralization. And this is a very important one. You have to describe the demineralization, which will differentiate the different types. Okay, so if we go for the types of skeletal dysplasias, we will have some important ones which are very common and others which are extremely rare. The one which is common is thanatophoric dysplasia, meaning in Greek it is the death-bearing. And this is type of abnormality which is mutation. So the father and the mother are normal and the recurrence is nil. So this is very important to diagnose it because of there is no recurrence. This is lethal, however, there is no recurrence. The characteristic feature is either we have a telephone shape or we have a craniosynostosis giving the liver leaf. This is type of you see here, this is the limb, and the limb is totally curved here like this one. So this is a telephone receiver, and this is a type of craniosynostosis which is usually observed in late pregnancy if you diagnose it late. So ultimately, what is thoracic thanatophoric dysplasia? Type of generalized dysplasia, polyhydramnios with telephone receiver as well as mutation. So the mineralization is normal. Remember, all the mineralization is normal because we're going to have a similar situation with abnormal mineralization. This is the most conflicting and devastating type of abnormality, as well as it is testing your ability. The achondroplasia is usually late diagnosis, and this is a very big problem. So it's starting by 22 weeks, you find that the femur is far behind its normal. And then from that time, if you examine it every 2 weeks, you find that the femur is not growing anymore. So by a time of 29 weeks, you will have a final diagnosis of achondroplasia. This is a catastrophe because you are now facing a case of a type of skeletal dysplasia that's going to survive, normal survival time, even they are intelligent, and all the dwarfs which are living among us, even with the very famous history of the 7 dwarfs, are achondroplasic. So they are living with us. So how can we diagnose it? Actually, it is very difficult. You have to be very cautious when you are doing the 22, 24 weeks and the deviation of the femur from the normal. You have to go for all long bones and you have to have some type of experience, okay? Because this is a real challenging type of diagnosis. I'm just going to give you some examples of the most famous dwarfs in history. You know that we have this dwarf is this sneb. It's present in the museum, and you can see he is very lucky because he married a royal lady. When he married a royal lady, now he became a very like a lord, having some servants. And this is the most common one that you have heard in Adil Imam movie. I think you have seen Bess. If you remember the movie that he said Bess is his Adnadu Bukra ومش عارف ايه. This is Bess. Bess actually is a god of entertainment. It's present in all literatures, and it is a head of a lion and a body of a dwarf. So you can see it many times. Of course, if you go to the museum, find a lot of these. Some of campomelic dysplasia. This is type of dysplasia which affecting it's rhizomelic with scapula. Short rib polydactyly. You'll find always you will have polydactyly. Now we come to the second type, which is the demineralization. I will show you a type with achondrogenesis, and this achondrogenesis is characterized by everything with micrognathia, and in this case you can find easy the micrognathia recognized, and the most important is this one, is the demineralization. So if you compare achondrogenesis with thanatophoric dysplasia, the difference is demineralization. Of course, this is micrognathia, and this is also have polyhydramnios. Why do we have difference? Both of them are lethal. The only reason is the autosomal recessive, and the other one is no recurrence. So if the mother is asking you, is this going to happen to all my babies? In thanatophoric, no. In this one, you have a 25% recurrence. So this is the only difference. And this is the one I wanted very much to. Of course, osteogenesis imperfecta, you will find some work. I am sorry that I am going to pass because this lecture is very big. And I want to give you some idea about the most important is the focal limb dysplasias. This is one, if you don't follow the checklist of doing fetal anatomy, you will find facing mesomelic diastosis, rhizomelic diastosis, absent femur, just a femur is absent, or a radius is absent, or club foot, club hand, and so on. And hemimelia, absent fibula. Why are we going to miss it? Because we don't follow the cheat. We just measure the femur and everything's fine, and we don't search for the other segments. If you search for the other segments, you will find something missing, and in this case, polydactyly, of course, and so on. Let's go rapidly with this, the club foot. Club foot is a Talipes equinovarus, the most common type of malformations. It is often twice in males. 60-70% is bilateral and associated with three, either chromosomal, complex, or isolated. Okay? So if we are facing isolated one, then it's have to get by exclusion. Everything should be excluded. How can we diagnose it? This is the clue for diagnosis. We say simply, if you see the tibia and fibula and the plantar or dorsal surface of the foot at the same plane, this means that you have a club foot. So this is the one, and this is different types of club foot. As you see here, this is one in the 3D, can explain it to the mother. And this is another one, and this is the unilateral. This is a unilateral type. And we have clubbing associated with some abnormalities like megacyst. We have early clubbing, 13-week scan. And remember, we could have an isolated familial. This is common. So the type of having clubbing could be completely normal. But how can we say that's normal? You have to exclude all other causes. If it is normal, then the outcome is excellent. Immediately post-term, post-delivery, on delivery, you put the leg in cast. Just casting for 1 year or 2 years, everything will be fine. So this is some of the skeletal diagnosis. Could be part of trisomy 18. And it's not warranting doing amniocentesis, except if you have other findings. Okay, polydactyly. What is polydactyly? It is post-axial or pre-axial parts, and usually we find 5 digits. It's extremely important to ask about family history. This is like syndactyly, because we have a great association with many syndromes, like skeletal syndromes, like congenital heart, trisomy 13, Mickel-Gruber syndrome, as I'm going to show you now. This is a classical Mickel-Gruber triad of encephalocele, polydactyly, and polycystic kidney. This is from 13 weeks you can diagnose, and you can have an autosomal recessive disorder. Polydactyly isolated familial in 50%, trisomies could be 1%, and part of an autosomal recessive syndromes in 25%. Others, let's go to the focal club hands, like the radial anomaly, absent limb, or dysplastic limb. Extremely important, please, because this is very distressing for the mother when she finds out that one of the radius is not seen and he did not diagnose it. So the club hands could be upper hands, like this is the club hand deformity, radial or ulnar. The most common is radial club foot, radial aplasia, and so on. Let's see some spectrum. Trisomy 18, Holt Oram, and Fanconi, thrombocytopenia, absent radius, called TAR, Roberts syndrome, and Vactrel, which is a combination of many types. This is the classical image of what we call the radial ray anomaly, radial clubbing. You find that either the ulna is usually also dysplastic. There is a certain types like called TAR. TAR is a thrombocytopenia and absent radius. The problem is it is autosomal recessive. Why I'm telling you this? Because I have facing a case of TAR, and when I diagnosed it as STAR, I'd asked her, why did you stay until 20 weeks and you didn't come earlier? Because we can see this earlier. She said that I have a baby with STAR, and it been 8 years trying to heal him and doing operations. Then I waited to have another baby, and her doctor told her, you don't have to do ultrasound at 13 weeks. It will not appear. So we have to wait until 18 weeks. So when you waited until 18, 20 weeks, now it's time that once you go to the doctor, tell her, I can't do anything. We are now beyond the limit for termination. I'm just telling you that it's at 13 weeks, you can salvage many operations. You are going to decide, this mother have already a TAR, and this is the second one. What are you going to do? Of course, you will have the right to do termination in the second one, and you can diagnose it earlier. So remember that this is an autosomal recessive disorder, which is the TAR. Thrombocytopenia and absent radius, as many, and this is about 3 cases I have seen them. So the thumb is the determining part. Sometimes you see very rare hypoplastic humerus, dysplasia 2. And we can see hemimelia, which is the absent fibula, as well as dysplastic femur. And in this case, the only way is to amputation above knee and make prosthesis. I will tell you the difference in fetal medicine between our communities and other community. I have presented this case, and I tell that we managed to terminate early, less than 18 weeks. When Philippe Genti presenting same case, he presented a case and he brought the lady, it was like 14 years after that, and she was putting a prosthesis and skiing on the ice. So it is different attitude, okay? I mean, if you can do, then you are managing. If you cannot give the normal life, then you should give her the chances of early diagnosis, since she can decide what to do with this. So, ectrodactyly is something which is not very common. It is widening of the middle with clifting of the hands. It's chromosomal abnormality in 18. Could be Roberts, like this one. This is an ectrodactyly. Arthrogryposis. I think we have 2 other types. Arthrogryposis is a very dangerous one because actually, again, it is a late diagnosis. What is the problem? We don't know. It's a joint, muscle, connective tissue. And it is sometimes autosomal recessive. So don't be happy, and every time you do ultrasound, you find that the legs are very nicely in front of the face, and you tell her that this is a ballerina and so on. You have to enhance the movement of the limbs, and you see by eyes the movement of the terminal joints. So the movements of the hands, of the legs, should have flexion and extension. If she sustained this position, with a sustained position, no movements, repeat, and no movement, repeat, then the diagnosis of arthrogryposis would be commencing.
5 minutes, please.
No, we have less than 5 minutes. So obstetrical management is counsel parents when diagnosed. Optimal delivery is at tertiary center, and sometimes cesarean section seem to be the best way of doing it. Remember, there is some syndromic, like Pinot-Choquer syndrome, which is associated with polyhydramnios, and it is autosomal recessive. The last thing I'm going to speak about is the difference between what we call amniotic band and amniotic sheets. Amniotic band is a very simple band of amnion that may be early in pregnancy, becomes entangled around the limb or a thumb and causing amputations. It can cause some drastic effect on the fetus. You cannot see it, but you can see its effect later on. Early disruption, later disruption, most cases of skeletal, like clubbing or so. Ultrasound appearance is a band appear as thin membranes. It may cause facial clefts, limb amputations, as well as others. But this is an amniotic sheet, which is different. This is a separation of part of the decidua, and it is not related actually to the fetal part. So you can see a very thick one, which is on one side, and it is not part of the, nowadays, not part of the amniotic sac. It is a detached one. So it doesn't have an effect on the fetus. This is a very simple table to differentiate between the amniotic band and amniotic sheet. Amniotic band, as I told you, can cause severe malformations, while the amniotic sheet is not causing severe malformations. So, as a conclusion, I hope I didn't have too much knowledge. Assessment of the fetal skeletal dysplasia should take the following steps. Generalized or focal, you have to determine, is it a generalized type or focal one? Which limb is affected? Is it a generalized? And which part is affected more? The burden is on the femur or whatever. What are the associated anomalies? The follow-up and counsel, considering most probably in the generalized skeletal dysplasia, we are speaking about either it is recurrent or not, because most of them, as I told you, are lethal parts. The strategy of treatment comes to the focal dysplasias. In focal dysplasias, you have to determine classically what's the type. Is it isolated? It's associated with complex abnormalities. In this case, you will ask for more interventional procedures like amniocentesis or NIPT if you are early. And then you are going to inform the parents about the outcome. As I told you, if it is an isolated abnormality, it could be handled like the clubbing, or it could be a very obstacle for the future, like the radial ray anomalies and others, that you should be let the parents facing the facts of that. Thank you very much, and I hope I didn't have exceeded my time.
Thank you for sticking to the time. Because this is a very complex issue, the skeletal dysplasia, and most of the audience are general obstetricians. So can you summarize in like 2 sentences what things the general obstetrician should be looking for? Because they certainly cannot go into polydactylies and the various abnormalities. So what's your guidance for most obstetricians?
Okay. If you are doing the ultrasound, remember that the 13-week scan is extremely important. In skeletal dysplasias or skeletal examination, the best time is 13 weeks. Can you imagine? Not the generalized, because the generalized are actually lethal. You cannot do anything. While the focal, you can see it from 13 weeks. And this is easy. So, whenever you are doing 13 weeks by yourself, or you are referring, if you are doing by yourself, it's easy to see the limbs. You can just count the segments. George have presented in France that you have the certain segments. You see that the hand is so and so, the upper arm is humerus, tibia, radius and ulna, and hand. You cannot miss this. Number 2, remember that 13-week scan is important. When you go for 20 weeks, you are doing a scan for your lady. What are you? You have to get your learning curve for seeing all the limbs. This is very simple. Just comment or document the presence of all limbs. If you cannot do this, you have to refer your case. If you cannot see the segments, please, somebody is going to do it for you. When you see the report, it's very important in the report to see all limbs are seen. This is responsibility. All limbs are seen, and as well as the measures.
Let's move the question to Dr. Maher.
Thank you, Dr. Ala. Skeletal dysplasia is rare, but they're devastating to the family. And when you diagnose them, you're stuck sometimes because it's advanced. Now, my question is, do you do genetic testing on all these families? And do you have guidelines on how far can you go for future? Because the next question after whatever, either you terminate or you continue, is what's going to happen in the next pregnancy? Thank you.
Generalized skeletal dysplasias, you have to differentiate the type. Is it synatophoric dysplasia or achondrogenesis? And other types. Synatophoric, no recurrence. You can see it with guarantee, and this is always, I found a defect in the report. This is a case of thanatophoric dysplasia, the recurrence is nil. Of course, you have to document this postnatally, but anyhow, at the time. Achondrogenesis is very clear. You find marked demineralization with micrognathia. Other types will show itself. So this is generalized. In the focal, you are entitled to do invasive procedures or an IPT in certain situations. For example, polydactyly, and you find it bilateral or something like post-axial, and there is no family history, and you are thinking of something in the fascias and so. You have to do interventional procedure. Club foot, the same. Okay? However, if you don't find anything and everything's fine, you may not do interventional procedures. Genetics, for example, as you have mentioned, TAR syndrome. This TAR syndrome should have genetics because it have a gene which is autosomally recessive. So from the doctor that diagnosed case as a TAR, he should say for the mother and the father, the next pregnancy, we should do something for this from the beginning in order to say that it is TAR, or from the first beginning you can do PGD or whatever type of selective embryo for the implantation. So definitely yes.
Okay, one last question. The doctor in the back. Can I
most Arab countries permit termination for maternal health reasons. You mentioned that we can do termination. Does the Egyptian law permit termination for fetal reasons, and up to what age?
The Egyptian law does not allow termination.
Full
Just
stop.
one sentence. No allowing termination at any means.
Okay.
The second thing is that when I say termination, if you take it from the religious, then you have to consider all religions. For the Coptics, no termination.
I'm just asking.
Just please let me continue. For the Coptics, no. For the Muslims, you have to follow. Some of the sheikh say that it's 120 days from the time of conception, which is 4 or 5 days. So if you ask the fatwa, they tell that you can terminate based on the mother or the fetus, not the mother alone. After 120 days, it is mother only. Okay, so this is the religious part from Muslims in Egypt. Different in Saudi Arabia, different whatever. I'm just speaking from the point of being a fetal medicine. I do not interfere with the decision what she's going to do. I'm just giving her the data, giving her the most important information. According to her situation, she may say, I am going to have this baby. Totally right. I am going to get this baby. She take a fatwa or whatever. I am not concerned with this. I am concerned with giving the mother the chance of knowing her fetus scenario or future starting from 13 weeks scan.
Okay, thank you, Professor. And we'll move to the next talk. Thank you.
Our next speaker is Dr. Srividaya Sankran. I hope my Indian pronunciation is good. Fetal medicine, doctor at Evelina Women Children Hospital, Gaze and St. Thomas's NHS Foundation Trust in London, MBBS, at the Tail Nadu Dr. MGR Medical University at Chennai, India, a fellow of the Royal College of Obstetricians and Gynecologists at the United Kingdom, with the she's subspecialized and accredited in fetal maternal medicine from the General Medical Council of the United Kingdom. Please, doctor.
Thank you for the kind introduction. I'm just going to talk about the common abnormality that we pick up on the scan. You know, compared to brain and the heart, we will never miss a kidney problem because it's full of fluid and it's staring in your eyes. This is something that all of us come across very often. And I do a monthly clinic with our pediatric urologist. So what I have learned working with them for the last 15 years is that we need to know what the pediatric urologists do so that when we first talk about the diagnosis, we build the expectations right for the parents. So it is the commonest abnormality we'll pick on the scan, and it is about 20 to 30% of all ultrasound abnormalities. And most of them are picked up at 20-week scan, but with the routine 36-week scan, we also pick up additionally 0.21% of abnormalities. And major abnormalities ending up in second trimester, it contributes to about 20%. It's overall in England where the law for abortion is liberal, it still contributes to a very, very small percentage of total abortions. And we are pretty good at diagnosing what the abnormality with kidneys, unlike the heart or brain, which is more challenging. So I'm hoping to go through all this. If I run out of time, of course, I'm happy to stop. So I just will start with the condition, that we come across with large bladder, because that's what first we see at 12 weeks. So the commonest is posterior urethral valve in a male fetus, but of course there are also other possibilities like chromosomal abnormality and rarer genetic conditions. So in first trimester, when you see a large bladder, how do you confirm? So you measure the length of the bladder, and if it is more than 7 millimeter persistently, not just one scan persistently, then you start thinking this is a large bladder. And again, if you measure, and if it is between 7 and 15, it's more likely to be a chromosomal problem than a urological problem. But if it is more than 15 millimeter, less chance of it being a chromosomal problem, but urological structural problem. So then, we follow them up, and in second trimester, the large bladder definition is slightly different. If you're not sure, if you are looking at a bladder enlarged, again, measure the length of it. If it's a gestational age plus 7, for example, at 18 weeks, if your bladder measures 25 millimeter, then you know it's a distended bladder. If it is more than 12, then it's definitely a megacystase that is likely to be a urological obstruction. So the next thing is, when you say large bladder, look at the bladder thickness. As a guide, we say more than 3 millimeter, but of course with gestation, with the amount of urine in the bladder, all that will have an impact on it. For example, in the third picture, it's much more clearer. Even without measuring, you can say it's a thick-walled bladder. And if you find a thick-walled and distended bladder, then more than 90% of the time there is an obstruction there and is highly likely associated with PUB diagnosis. Of course, we are talking here about male babies. The keyhole sign, which we are all obsessed with, actually it is, it's present only in 52% of fetuses with PUB, and it can be present in other conditions as well, so it's not very specific. The next thing is you go up and look at the kidneys. If you say bilateral hydronephrosis with a large bladder, then most likely it's a PUB. And if you also find dilated ureters, it adds to your diagnostic conundrum. And in some extreme cases, you also find urinary ascites. I think in female fetuses, I have found urinary ascites earlier on in gestation more than in male fetuses. For some reason, the system enlarges and stretches. And then, I don't know about the rules here, but in England, we can look at the gender of the baby and if the parents want to. So if it's a male fetus, then again, most likely PUB. Then we look at the Leica volume, because now we are made the diagnosis, we have to move towards prognosticating it. So if you find oligohydramnios, which you find in 50% of cases with PUB, if you have normal Leica volume, that doesn't rule out, because 38% of the cases also have normal Leica volume. If you find normal Leica volume, then you can start prognosticating about the renal function, because the perinatal survival is 90% and renal replacement therapy will be needed in 1/3 of cases. So for example, at 20 weeks, you have seen fluid, and then the fluid has become less, then that chances start going down. So in these cases, survival is 61%, and severe pulmonary hypertension recurring respiratory support is about 10%, and chronic kidney disease is more than 50%. So if you see at 20 weeks PUV and less LICA, look at the chest circumference, because here our concern is not about the kidney but about the development of lungs. And then to be complete, look at the other systems very carefully. Sometimes, it is not very obvious in earlier scans, but later scans, you start getting dilated bowels. And also other structural problems will give you suspicion of chromosomal or genetic problems where you will be counseling about amnio. So if you follow these babies further up, at 34 to 36 weeks, you can see the bladder thickness is much obvious, especially when the kidney produces less urine, but the bladder is small, the thickness is much more obvious. And now, we have the benefit of fetal MRI to complement our ultrasound diagnosis. So again, you can utilize it. And we don't do this, but if your lab has got the capacity to do the fetal urine biochemical evaluation, that is quite helpful. And you can see that it's not the protein, phosphorus, glucose, which were tested in the past. They are not very useful. So you have a case of this. So how, because most of the question is about the parents are asking, what will happen to my baby? Will my baby need renal transplant? So then all these factors that you have identified on your ultrasound will help towards prognosticating. If you find oligo or anhydramnios, if the parenchyma is thin, or if it is dysplastic, or if it's echogenic. And now on the MRI, there's also lots of studies have reported on ADC. If you have that information, all these things will help in prognosticating. And also in LUTO, which is a lower urinary tract obstruction, staging has been proposed by Professor Ruano's group. So you can see that if they are in stage 1 and 2, they are much better prognosis, whereas 3 and 4, poor prognosis. So when we diagnose, we get them to meet the fetal pediatric urologist, pediatric nephrologist, and sometimes if we suspect other problems, clinical geneticist. And when we know the prognosis is poor, but the parents do not want termination, we also put them in touch with the pediatric palliative care team. It is a very much a team effort and a continuation of pregnancy, and be willing to review the discussions as the findings change. And interventions for LUTO have been in place for a very, very long time, and the vesicoamniotic shunt, and also in Europe, they do try the fetoscopic ablation of the posterior urethral valve. So how does it look? The shunt is effective, but the overall survival rate is slightly less than the fetoscopic. But the problem with shunt is if you put one shunt, be prepared to put 2 or 3 more shunts in the pregnancy, because it gets displaced, it gets obstructed, and so you may have to do more than one in pregnancy. Fetoscopy, I think earlier people tried in earlier gestation, and the urethra has not developed, so it has caused perineal fistulas. Whereas now the studies are looking at doing it a bit later, but we still haven't got a big data to confirm this. So overall, it does improve survival, but it doesn't say whether when you put a shunt, whether it improves the renal function. So as a guide, what we do is, if we find oligo or anhydramnios between 16 and 24 weeks, we definitely, and if the woman doesn't want termination, we offer shunt. If the amniotic fluid volume is normal, then we actually do the expectant management. And in Germany, people have started looking at putting a shunt very early in the first trimester, following the first trimester diagnosis. But the initial findings are mixed, with claiming it is better, but there is an increased pregnancy loss. But with the Somatex shunt, the advantage is the displacement is very less compared to Harrison shunt. So in summary, it's only a very small proportion of your population when you get this classic findings, but many times it can happen also without the classic findings. So we do, provide a continuity of care throughout the pregnancy, which results in better experience and outcome for the baby and the family. So if the same case, if it presents with anhydramnias, so our counseling will go in a completely different direction because we know that amniotic fluid is necessary for the development of the lung between 16 and 24 weeks. So if it is not there, the lung is not going to be developed. So it's a non-starter for life. So it's been a recognized condition called early pregnancy renal anhydramnias. Because by 90% of the amniotic fluid is contributed by fetal urine from 16 weeks. And if you don't have, then these babies have lung hypoplasia and are likely to die. You can see that in not only in lower urinary tract obstruction, you can see it in bilateral conditions. So the amnio infusion has been reported in case reports from the US, and many times parents have asked us, can you not do that? The results are not very strong evidence-based, and so the trial was started in the US, but I've been looking out for the results. It's not yet published. In the US, in some centers, they do serial amnio infusion. If you're interested, there is a YouTube link. You can go and watch and how they can keep a port through which, rather than going every time into the uterus with a needle, you can infuse amniotic fluid. So here, because of anhydramnias, it's not only lung hypoplasia, there is compression, abnormal facial profile, flexion deformities. So the prognosis is quite poor. We offer termination. If the parents want to continue, then we offer shunting with unclear benefit and the risk. We have put shunt in one of the case, but still it hasn't helped because the kidney functions have gone off even before that time. So you can see as the pregnancy advanced, the bladder was hardly visible, the kidney was dysplastic. Sometimes, you don't see a hydronephrotic kidney in late trimester. In fact, it has become dysplastic. And then had a narrow chest, and we estimated lung volume with the MRI, and this all helped in counseling the parents, and we redirected towards, this is the normogram for the fetal lung volume. I think Lisa is doing quite a lot of study on that. So, in these cases, we facilitate compassionate care around birth, and we recommend postmortem examination. So if anyone wants to know more about posterior urethral valve, I would recommend you to read this article from the French group. It's brilliant because they have started from the fetus, because now pediatric urologists are aware that, they need to know the baby from the fetal stage, not when it is born. And definitely I get a good support from our pediatric urologists. So now going to the bread and butter of fetal urology is our hydronephrosis. And I think, if I have to say one take-home message is, please don't make the parents anxious because only a very, very small percentage of them need surgery. And that's all I have done in the last 10 years is to give that information upfront so that when the baby is born, the parents are not excessively anxious. So in the transverse section, and I think we have trialed out so many measurements, but the only measurement that has stood the test of time is the anteroposterior diameter of renal pelvis. So on transverse plane, we have to measure this. Many times people measure it in the longitudinal plane. That's not correct. It's the transverse plane. And in the longitudinal plane, you can look at it to see if there is a calyceal dilatation. And then you look at the bladder, because if the bladder is not enlarged, then you are dealing with an isolated hydronephrosis. It's very common, and 80% of the cases it resolves. It's only in 20% of the cases it persists and needs some additional intervention after birth. So we talked about anteroposterior diameter. So, in the past, when I started the clinic 15 years ago, I used to get referral for APD of 3 millimeter, 5 millimeter, but now, the national guidelines in the UK are very clear. If they are less than 7 millimeter in your anomaly scan, they don't need anything further. So they don't get followed up. If it is more than 7 millimeter, then they get referred to the fetal medicine clinics. In the third trimester, the threshold is 10 millimeter, obviously more urine production, so the measurement is slightly higher. And the SFU classification has also included, but this is very confusing, so we don't follow it. We find the UTD classification more helpful because it takes into account parenchymal thickness and calyceal dilatation and ureteric dilatation. As we all know, the males are overrepresented in this population. I just wanted to add this because when we see them in the fetal medicine clinic, we start talking about what is going to happen after the baby is born. And one of the changes that we have done in our clinic is we use less and less antibiotics after the baby is born. This needs quite a lot of communication between the fetal medicine person, neonatologist, and the pediatric urologist. And we have looked at the evidence, and we have now we hardly ever use unless there is an ureteric dilatation or severe hydronephrosis. Because if you start giving prophylactic antibiotics, when these babies really get infection, none of your antibiotics works. So to reduce antibiotic prophylaxis, don't do routinely. So this is our guidelines. We divide them into high risk, moderate risk, and low risk. And one of the changes we have done recently is because we are now doing a lot of 36-week scan, we have stopped doing the postnatal 1-week scan, which is a very awkward time for the parents when they are getting used to the new baby. So because we get all that information at 36-week scan, we triage at that level. And if it's a unilateral hydronephrosis, we bring them back at 4 weeks after baby is born. And we give antibiotics only for severe cases and ureteric dilatation. Talked about the moderate and low risk. Duplex kidneys, I get so bored in my clinic. I'm not interested if there is no urinary tract dilatation. Only be bothered about duplex if you have associated upper urinary tract dilatation, because we are not going to do anything differently to these babies. And sometimes I don't even think we diagnose them properly prenatally. But if you see a cystocele in the bladder, then it is highly. These are the ones that will benefit by follow-up. These will need antibiotics and referral to the urologist. So there are various types of duplex kidneys. Again, prenatal scan, this is a systematic review. Lots of studies have been looked at. It's been confirmed in 91%. Only 34% of them need some sort of surgical intervention afterwards. So that is, if you are missed, it's not the end of the world. These babies present with UTI or something postnatally and I don't think the outcome changes if it's a prenatal or postnatal. So coming to cystic kidneys, obviously the multicystic dysplastic kidneys is something we commonly come across. If it's unilateral, we don't talk about genetic problems, but if it's bilateral, then. So always look at the other kidney, look at the rest of the baby. If there is association with anything else, then offer amniocentesis. Invariably, these kidneys do not have renal function. Occasionally, we see cortical cysts. Cortical cysts have got good outcome if there is no associated hydronephrosis. Perinephric urinoma, I think we have changed a lot of our ideas about, we used to think that was bad, but now we know that the kidney that ruptures actually protects the function of the kidney. So if you see the perinephric urinoma, you only drain if it is causing compression of the, otherwise it's a self-defense mechanism by the baby. Sometimes, when you see some echogenic kidneys, you don't know how to classify them. Offer genetic testing, they would sometimes be a sign of a metabolic condition. And nowadays we are seeing a lot of ORCAD, which is the renal cyst and diabetic, which is due to HN1 beta mutation. So think of, if you see bilateral cystic kidneys, think of genetically inherited kidneys. The other thing I would say is if you're not seeing the kidney, so if you're not seeing the kidney, it doesn't confirm renal agenesis. So look carefully on the other side. It may be a lower, it may be a pelvic kidney or an ectopic kidney, or it can be a crossed fused ectopic kidney. So always counsel them saying this is a possibility. Otherwise, parents get really very upset. And later on, if you find another kidney, it can be missed because sometimes bowels can be mistaken for a kidney. Look at the other kidney and renal, extrarenal abnormalities. So congenital single kidney do well. That's why people do donate. And of course, we now have a special clinic where they follow up these babies later, but not very frequently. But if there's associated with other abnormalities, you have to think about genetic conditions. So specifically, I want to talk about the female babies. There is a condition called ovira, which has been identified where the babies have renal agenesis and unilateral obstructed vagina. So they are associated with the Mullerian duct abnormalities because of the embryological origin. They both come from very similar system. So now this is our latest interest because I have a pediatric adolescent gynecology colleague, who says, lots of babies are later on coming to them. So there is an increasing evidence that if you electively manage them, you can reduce the long-term poor prognosis like endometriosis, infertility. So watch the space. I'm sure more information will come. So sometimes we come across complex urinary tract abnormality antenatally. For example, this was a case of hydrometrocolpus. Initially it looked like a large bladder, but if you see clearly, it is posterior to the bladder. And this one needed drainage even before the baby was born. Yeah, I think it was a very fast whistle-stop tour of the urinary tract abnormality.
Thank you very much, Dr. Srividaya. We'll allow questions here, and thank you for saving us 4 minutes.
Brilliant.
Thank you, yes. Dr. Omar, تفضل.
Thank you. Once you don't do the biomarkers for renal functions, does that make sense to say shunt subsequent renal failure for the baby? And the second question is, do you think the Harrison shunt is too small to drainage the bladder? Is there alternative shunt for that?
Yeah, I'll come to the second question first. The Harrison shunt it's not because it is narrow, but it is because, the baby grows. And also once you put the shunt in the bladder and the bladder shrinks and the bladder withdraws, and with the baby's movements, or sometimes even the baby can pull it because it is in the front. Whereas in Somatex shunt, there is a little bit of a valve-like mechanism, so it cannot easily be pulled. I think that's why they did build the Somatex shunt to overcome that. That's why they built the Somatex shunt to overcome that pulling effect. And I had a pediatric urologist who is retired now, and she was very passionate, and she said, why can't you do something like a suprapubic catheter where you put in and inflate the balloon? If anybody who is interested in bioengineering, I hope we will develop something like that so that we can put an inflate and it won't come off.
Any more questions?
Yes,
Yeah.
just I have a question, but to answer you, more and more in France, we don't use shunt. Now we privilege to do fetoscopy. We enter in the bladder, and then we see if there is a POV, and we use the laser to make a hole and to repair. And like this, it's better to shunt. So for this indication, this is why we'll discuss in first trimester. When you see this in first trimester, we do fetoscopy, and we go to see the obstruction via the bladder, via fetoscopy and via a cystoscopy, a fetal cystoscopy, if you prefer. And then we go by we do this more and more with EVIL. We are doing this. We have done last year. We have done 3 cases from my hospital. It's
I think the initially there was hesitation because the earlier studies showed some perineal fistulas, but now I think because of the flexible scopes and also doing a little bit later, those problems can be averted. So it will be interesting to see as you build more experience and publish.
Yeah, I think
and also my excuse me.
Go ahead.
And my question is, first question, you have to say that every time that we have a problem with kidney, urologic or nephrologic, you have to do the scan of the parents. This is very important because we have more and more things to learn. And my second observation is that with genetics we know a lot of things. Before, when we have adult polycystic and we have hyperoncogenic kidney, we say it's a new form for kidney, it's okay. Now you know that it's different because we have a mutation of an adult that baby have taken from his mother, for example, and they have another mutation, less aggressive, and this is why the expression is in prenatal. So now we are doing genetics exam.
Yeah.
Every time I have a nephrologic problem, I ask for NGS. NGS is new generation sequencing for kidneys, and we are looking for a lot of new mutations will give the prognosis better than beta 2
Yeah.
because it will gives you the evolution of the we'll discuss in first time, sir, but thank you.
Yeah, I think you were right. I think we do have increasing incidence of the ARCAD and adult ADPKD now. I mean, in the past we used to say don't screen for adult onset kidneys, but now you can't ignore when there is an echogenic kidneys on the scan. But usually, they have family members who have survived to adulthood, so most people opt to continue pregnancy.
Dr. Nail.
Thank you very much. Just, I want to ask you if there is any role for repeated bladder aspiration, especially in cases of POV in the presence of severe megacystis. The shunt is usually not feasible and not available in most of the centers. And if you have done any cases like this.
So I think we have shunt available. In some centers, I have spent some time in Toronto. They do routinely aspiration before they put the shunt in because it tells you about the starting function of the kidneys, and it makes sense to know the function of the kidney before you put the shunt in. The problem is, if you put the shunt in, at least it lasts for 2 or 3 weeks. Sometimes we have put one shunt and it lasted till the baby was born. Rather than going repeated needling, which increases the risk of infection and miscarriage, it makes more sense. But of course, if you don't have that availability, then you can consider aspiration, or you may refer to another fetal medicine center who have the expertise.
Yeah, thank you.
I have a question for you. I've been waiting for some time. As a pediatrician, I just wanted to ask you, if you see the autosomal dominant type of kidney disease, what do you do? What do you counsel? Number one. Number two, what's the role, as Professor Haddad said, genetics? Do you do, now you have a renal panel, or you do whole exome? What is the standard in your practice? Number three is, do you allow abortion? What's the rule in the UK?
Yeah, I think it's a very important question which is becoming more and more prevalent. So first thing is, we take a good family history, we refer to the clinical genetics team, and sometimes, you know the genetic defect in the family, and then we offer. But from my experience, when we offer for ADPKD, usually parents are very happy to wait until the baby is born and test. So we do have ADPKD, we have got cystic kidney panels is there, which test for, but now with the whole exome sequencing, we are going for whole exome sequencing straight away in those situations. Yeah, I think, that's how we have diagnosed lots of this ORCAD syndrome, which was not easily picked up in the past. So we do, and our nephrologists, pediatric nephrologists, they do a dedicated clinic for follow-up of these babies after they are born. So that is one of our pediatric nephrologists has interest in following up these cystic kidneys, and so we plug into the system, and so it is like a continuum. It's not like we're just only treating the baby in the pregnancy, and we put them in the.
But this is important, like in counseling. Supposedly the mother will go, I mean, if this is an autosomal dominant and the baby is not going to do well, do you counsel them? Because for the MFMs, I think it's very important that we know the genetic sequence antenatally, and if we know, if we go to go for cesarean or not, these questions, it's not important. We can all wait until the baby is delivered and then we do the genetic testing. I'm talking about antenatally. Does the NIH cover if she wants to get rid of the baby, is it allowed? Do you have by law to do genetic testing before you allow that? What's the system there?
Yeah, I think, most of them have normal amniotic fluid, so it's not a lethal abnormality. So we treat them as routine in pregnancy, and if they need section, they do get section. I mean, most of the PKD families that we have looked after, there has been a lot of adults who have reached the adulthood. So I have not come across anybody who has requested termination for diagnosis of ADPKD. I'm sure, we will come across somebody, and I think in those situations we will do a multidisciplinary and ethical committee discussion and touch would be having come across that dilemma so far.
I think one of the main issues that we have in managing the bladder obstruction cases is that when you go through the selection criteria for instance, laser, you will be you will end up with a very small number. That's why in Jordan we probably have, if you had 3 in your center, we probably would have 1 or 2, because if you take out the chromosomal abnormalities and you take out the Prader-Willi syndrome, which is much commoner than actual PUV from what I see, the number of cases that you will end up needing to do shunts is very small, or laser. The other thing is, in order to do the diagnosis, as Professor George would know, you need later time for laser. And by the time you reach the time for laser intervention, the kidneys are already knackered. So it's not a straightforward intervention. Yeah. That's why the success rates in terms of improved kidney function is very limited in these cases. Thank you, Professor. And that was an interesting discussion. And now we'll move to our last speaker, which is Professor Munira Habli. Now, the session is recorded, so it's not live, but I would like to thank Professor Habli because she's instrumental in introducing, and when we introduced fetal surgery to Jordan, and she has been a very good helping hand. Can you start the recording, please?
I would like to thank the organizing committee, including Dr. Mahal Maita, Dr. Aklin, and other all organizing members for inviting me to do a lecture today. I have no disclosure. Maybe I'm going to address a few markers in the vein, urinary tract symptoms, GI, and in the skeletal system. We'll start with the renal pelvis dilation. As we all know, antenatal renal pelvis dilation is one of the most common fetal anomalies detected in pregnancy. The ultrasound can detect up to 91% of sensitivity. The most common causes are transient physiology, uretropelvic junction, uretrovesicular reflex, multicystic dysplastic kidney, and PUV. This is a nice picture that shows the different type of obstruction. For example, here is uretropelvic junction, which causes renal pelvis dilation. If you remember those pictures, you can definitely have a 3D of the images on ultrasound. This is uretrovesicular junction obstruction. This is duplication of renal system. You can see there is a hyperuretan and upper or lower pole of dilation. This is duplication of the renal system. Here, when we have a reflex, you could see complete renal dilation. Here, duplication of the renal system with a reflux. Here, when we have urethral atresia, and here, when we have posterior nasal valve obstruction. What are the things on an ultrasound we need to report? These are the things we need to report. First, I will start and I'm going to show images of that. Renal pelvis dilation usually is measured in an axial section where we have the spine is either at 6 or 12 o'clock, and the normal range less than 28 is usually 4 millimeter, 7 millimeter, more than 28, postnatally 10 millimeter. Also, we assess the cavitary dilation, whether central or peripheral, the parenchymal thickness, appearance of any echogenicity of cortical cyst, and the ureter and the bladder thickness, the blood presence of erythrocytes, and also the dilation of the urethra in addition to amniotic fluid. As you can see here, we have an axial image of the level of the kidney. So here is the spine, this is the right kidney, this is the left kidney, and we measure internally the renal pelvis dilation. This is a coronal image with Doppler flow to make sure we have bilateral renal artery. And this is another coronal image of both left and right kidneys showing thickness of the parenchyma, is there any cortical thick echogenicity. And here is an image of how we usually know about calcium dilation. The first image where we have pelvis dilation, that is a smooth contour. Once we have some contouring changes and branching with fluid accumulation, this is ventral calcium dilation. And when we have cupping of fluid, as seen here around the pyramids, this we name it peripheral calcium dilation. When they start become more severe, we will have ballooning, as seen here, of peripheral calcium dilation. That ultrasound images they look. The first image here, when we have right and left renal pelvis dilation with internal measurement, as you see of the renal pelvis. You could see here the parenchyma is usually slightly echogenic. On this image, we could see how we can with the peripheral and the central calcium dilation. In this image, we could see first stage of peripheral calcium dilation where we have cupping. And in this image, we could see renal pelvis dilation, decrease in renal parenchyma, thinning also on renal parenchyma, and also ballooning of the pyramid as seen here, which is severe form of peripheral calcium dilation. On this image, we could see the high-ureter assessment. This is an image showing here the right kidney actually, and here is the bladder, and you could see we could have thickening of the wall of the bladder, enlarged bladder, thickened wall, no evidence of urethrocoel, and there is urethral dilation. This is the same image showing how the left side also has renal pelvis dilation with central pelvic calcium and peripheral dilation. How we classify urinary tract dilation or renal pelvis dilation? The general old classification was mild, moderate, severe based on gestational age as seen in the table, less or more than 28. But the most recommended one by our society and the Society of Pediatric Urology is to use the low and the high risk. And the categories that we usually assess, similar to the checklist I have, in the low risk, mainly we have only renal pelvis dilation, 4 to 7, less than 28 weeks, and 7 to 10, more than 28 weeks, with center calcium dilation. Then the high risk is when we have more than 7 at less than 28 weeks millimeter, and renal pelvis dilation more than 10 millimeter at more than 28 weeks, and any of those abnormalities that are present. Now, questions that usually patients address to us, what to tell them. Can this be more than one kidney problem? Yes, it can be. It can be isolated, not caused by any genetic or chromosomal abnormalities, just a structural abnormality, or could be multiple single gene mutation, we name it the gene or the CAT gene panel. It can be also associated with chromosomal abnormality. The most common is trisomy 21, where it is about 2.4 likelihood ratio to have. Other common associated syndromes like Bachelor, Cromwell syndrome, or DeGeorge syndrome. What future tests are recommended before delivery? We usually do an assessment of the genetic probability for the mom. We offer them non-invasive prenatal findings, and also based on the constellation of ultrasound finding, we can offer amniocentesis to check for chromokaryotype and the microarray analysis, and add to them the gene panel. But we recommend if there is more than one associated findings other than the renal to do a whole exome sequence, because 20% could be detected by whole exome sequence that are pathogenic variants, even if we have a normal karyotype microarray. Now, what is the chance of resolution of this renal pelvis dilation? Based on the severity, the less severe, the higher chance of resolution. As seen here, it's mild up to 90%, moderate up to 75%, if severe it's up to 44% resolution. In those cases that are born that isolated the renal pelvis dilation, the risk of surgery is 1%. But if there is severe dilation, especially the peripheral, the one which is the more severe one, or any other anomaly in the ureter or in the bladder, there is 9 to 14% risk of postnatal surgery. Now, what does mom will ask or, question, what is the risk of permanent damage for the kidney? The Brazilian group has followed about 400 patients up to 6 years, and they found that the renal pelvis dilation was more than 5 millimeters in the third trimester, more than 28 weeks. 5% of children could have the composite of hypertension event, proteinuria, and reduced glomerular filtration rate. And if it is severe, most of the baby could have chronic kidney damage. And another group has looked at if postnatally the renal pelvis dilation was more than 7 millimeters with any of the elements that I have mentioned before related to strength and ureter or bladder or severe abnormality. They followed them over 15 years, and those patients they found that 15% of those patients could have a renal pelvis dilation persistent, and about 40% could have some signs of permanent kidney damage. So it's essential when we find these findings on ultrasound to make sure we refer them to a neurologist. Now, what to do in the rest of the pregnancy? If it is a low-risk urinary tract dilation A1, we repeat another ultrasound more than 32 weeks, and those babies should have postnatally an ultrasound at more than 48 hours to 1 month and repeated at 6 months. We always, on those patients, consider non-invasive prenatal testing and refer them to an MFM. If it is high risk, then they need to have monthly ultrasound to check fluid, refer to MFM, and also they need to have an immediate postnatal ultrasound within 48 hours to 1 month of age. If it's an isolated finding, the timing mode of delivery should not be regular and obstetric. If it is more than one finding mode, then based on those constellation of findings, that could change the timing and the mode of delivery. We shift here to hyperechoic or echogenic bowel. It is about 0.2 to 1.4% of all pregnancies. 16 to 30% have poor fetal outcome. Hyperechogenicity is mainly the bowel could have single or greater echogenicity of the surrounding bone, and it is mainly related to meconium stasis or hypercellular type of bone. Most common cause in intra-amniotic bleeding, soft markers could be soft marker of communal abnormality, fetal blood restriction, placental insufficiency, infection, thalassemia, but also cystic fibrosis. Especially if the parents are known to be carriers, the risk of the baby having cystic fibrosis, if there is an echogenic bowel, 0.13%. If it is dilated, then the risk is about 17%. So whenever we have hyperechogenic bowel, mainly in the right upper quadrant or lower third quadrant, then we need to check for any cardiac anomaly, check for any GI anomaly, the asphyxia, bulbous, dilation of the bowel, biliary atresia, check for any urinary tract or any other brain anomaly. The work that will be done first, screening electrolysis, which is a non-invasive prenatal test. If it's not done, we will do it. If the parents are carriers, we check the parents. If both ended up carriers, then in genetic amniocentesis is needed to know the fetal genotype, send for infectious etiology, and also check for to make sure there is no fetal blood restriction. Now, what is the outcome? In the recent systematic review and meta-analysis actually looked at all the literature to see what are the outcome of patients who are diagnosed with fetal echogenic bowel. They find that there is a 3% could have trisomy 21, 2% cystic fibrosis, 2% could be infectious. The most common was fetal blood restriction, and 2% could be associated with other anomalies. And they found there is a high rate of perinatal death and only 0.4% neonatal death. This is just, I want to mention about the treatment if a patient is found to be cystic fibrosis. A new trial is going in the United States about using trifecta or the ETI, which are cystic fibrosis with transmembrane conductors, regulated and modulated therapies that are dramatically in non-pregnant patients change the outcome of TS. They found that these medications, animal in human studies, they could be found in fetal blood, They came cross placenta and they are found in breast milk. So it could be safe to use it. We don't know that while the study is ongoing, but in this study we included patients or babies who have confirmed CF/M decentesis and they have meconium illness on ultrasound. Why meconium illness is the indication because it is the most and earliest severe manifestation of CF, and most of these babies, if they have it, they will have surgical intervention, prolonged NICU stay, and they have a lot of digestive complications and poor growth. These are the first reported cases. Most of them were started at 30 weeks of age, and all of them had a fetal confirmation of the F50 500-08 deletion for cystic fibrosis, and once used, it was instantly showed evidence of resolution of the meconium areas. What about follow-up of those babies long term? There is one paper for 2 years. Those babies have been followed. I think it's from France, and they found that it was seen asthma and across the placenta. Complication post really was abnormal liver function test, cataracts, but we don't know the long-term neurodevelopmental concern. What are the, now I'm going to shift gears to the brain. I'm going to do markers in the brain. And we know the brain is in the early first trimester and second trimester abnormality. I will start with fetal microcephaly. Microcephaly is defined as when the fetal head circumference is more than 2 standard deviation, but if it's severe, it is more than 3 standard deviation. It is, the prevalence is 1.5 per 10,000 in Europe, 2.3 in India, and 6% in USA. As all of us know, neurons are usually generated by 21 weeks of gestation. So any insult before 21 weeks is mainly genetic or disorder or chromosomal abnormality, and this affects the neuronal and the glial proliferation. After 21 weeks, it could be ischemic infection or trauma, and this will affect the brain growth. And here is a table of some of the associated phenomena. And general diagnosis of fetal microcephaly is hard. It could be either over or underestimation because of methodology, what has to be used, and in some places where termination is allowed, this could lead to unassisted termination or could result to a not diagnosed prenatally and thus we have symptomatic baby at birth. The recommended head circumference reference range is interlock, and they have been found to improve the accuracy of our diagnosis to add other things to it. For example, if as seen here, if the head circumference less than 3 standard deviation with a family history of microcephaly, this is a 100% positive predictive value. If it is more than 4 standard deviation, also it's 100%. If we add to IGR, it's about 60%. If there's any other anomalies, for sure it's about 70% detection rate. What are the consequences of fetal microcephaly? As we know, the head circumference is a marker of neuronal growth. And if it is small, that means most likely if it's pathological, fewer neurons, and that could lead to neurodevelopmental delayed seizures and other growth and visual motor dysfunction. What workup and what do we need to do? If the fetal head circumference in a confirmed gestational age between 2 and 3 standard deviation, we should have an echocardiography, screening echocardiography, full anatomy scan. Patients should have detailed family history, especially consanguinity, some labs for TORCH and Zika virus if it is in your area, and or the patient has a troubled area that Zika is prevalent, and consider doing amniocentesis versus non-invasive prenatal testing. If all the workup is normal, we follow them every 2 to 3 weeks with a gross scan. If it is correlated, and then these babies are going to be followed postnatally. But if there is progressive decrease in the head circumference curve, then an MRI is recommended. But if the head circumference less than 3 standard deviation, as remember the 3 standard deviation in family history or 4 standard deviation is 100% positive predictive value, and MRI is recommended. fetal MRI is recommended to be found. If it's isolated finding, then we follow up with growth and postnatally. And if it is abnormal, the MRI, then based on the abnormality, the patient will be counseled and accordingly worked up. So it doesn't recommend any altering if it's an isolated fetal microcephaly, and the place delivery recommended is level medium. The second brain abnormality is corpus agenesis, the agenesis of the corpus callosum. As seen here in the image, in the sagittal section, and if you put color flow, you can see the pericallosal artery that highlights that we have in head, body, and the tail of the corpus callosum. And this is the second trimester showing the head, body, and the tail of the corpus callosum. And this is also has been shown when we put color blood flow, show that we have a pericallosal artery. What is the corpus callosum? The corpus callosum is a bundle of fibers that usually allow transfer of motor, sensory, cognitive information between the left and the right hemispheres. We could have either complete, partial, and in partial agenesis, it's mostly the posterior part that is usually missing, but the other parts also could be missing. It can be isolated, but if it is not isolated, usually it's associated with cardiac and renal abnormality. The most commonly diagnosed brain anomalies with the agenesis of corpus callosum is Denty-Walker, Vermilion hyperplasia, and other neuronal migration, polymicrogyria, or gray matter heterotopia. Also associated could be with the genetic abnormality up to 17%, in 4.8% in isolated, and 7.5% in partial. Most common abnormality 18, 13, and mosaic trisomy 8. Workup, non-invasive prenatal testing, and amniocentesis if it's indicated. We do usually fetal MRI to make sure if there's any additional brain abnormality that is not diagnosed in ultrasound and a fetal echo. The prognosis is wide, from normal to borderline neurodevelopmental delay, the risk of epilepsy, and something about 10% could have abnormal fine gross motor control. For that, we usually have those patients meet with our neurologist and meet your colleagues. Similarly, if it's isolated, should not change our timing or most behavior. The second common one is cavum septum pellucidum. As seen here on the images here of the MRI images, you should see on image A, the cavum septum pellucidum is here. It is fluid space between two ears of the septum pellucidum. It is the fourth most common reason for referral for neurology after agenesis of corpus callosum, ventricular mechanism, or cerebellar posterior fossa malformation. The importance of it because it connects the hippocampus and hypothalamus. So if it's absent, it can impact the function of both hippocampus and hypothalamus. It's about 2 to 3 in 100,000 and could be present with a variety of brain abnormalities. Testing for those guidelines from mainly is MIT. We can do amniocentesis, microarray, and possible whole exome when we don't frequent based on other findings, MRI, pediatric neurology, and nuclear consult. For postnatal workup, those patients have MRI based on their availability, ophthalmologic evaluation, in-between thyroid and cortisol testing. What is the outcome if a baby has isolated septum cavum pellucidum? A recent meta-analysis showed that in isolated septum cavum pellucidum, as usually they are normal developmentally between 70 to 94%, only 60% of those patients could have some oculovisual dysfunction, 14% could have a non-isolated, could be a complex type of absence septum pellucidum, and in those patients they have higher neurodevelopmental outcome abnormality, seizures, hydrocephalus, and impairment in hearing and in vision. So they would require additional postnatal follow-up. What about the short femur bone? Shifting to the skeletal system, What is the definition of a short femur? A short femur length is defined as the length below 5th percentile or 2 standard deviation for gestational age. However, SMFM also recommend biparietal diameter to fetal femur length ratio above 1.5 SD for gestational age or observed over expected less than 0.9 for gestational age. Another hint known as the first criteria is the femur length is less than 2 standard deviation, but only about 1 to 4 millimeter. We just need to follow that if it is isolated. If it is more than 5 millimeters, definitely this is high risk. We need to look for skeletal dysplasia. Keep in mind that short femur bone is affected by race and other familial factors. For example, Asians have shorter bone than Black Americans. It can be isolated either as a normal familial or could be wrong plating, so we need to check or could be associated with other anomalies. Regardless whether isolated or with other anomalies, most of these babies, if they have short femur length, they have an association or increased risk of fetal growth restriction, preeclampsia, or preterm labor. So a recent meta-analysis showed that an isolated mid-trimester short femur is associated with 4 times risk of increase in fetal growth restriction, low birth weight, low upgirth, higher incidence of preterm, higher incidence of fetal death, NICU admission, and hypertensive and neonatal death. So the American College of OBGYN recommends for a pregnant patient that has no aneuploidy screening and they found an isolated, recommend to counsel to estimate probability of Down syndrome and consider non-invasive aneuploidy screening, and if not present, quad screen. If the screening is negative and isolated, no more testing, they just recommend the ultrasound to assess fetal growth in the 3rd trimester, and antenatal testing even is not recommended, but some people we do it. If it is a non-isolated short femur, then if it is low risk, mild, usually we look at other markers. If it is low risk, we just do surveillance and measurement. If it's high risk, there are other markers of chromosomal abnormality, definitely amniocentesis. If it is severe, definitely we need to evaluate and do gene panel and whole genome sequences and comprehensive skeletal evaluation to rule out any fetal versus non-fetal skeletal dysplasia. So we reviewed several markers and several organs. I appreciate your time and thank you for your attention.
All thanks go to Professor Habli. Now we have a talk from ultrasound Mindre. They call it Mindre in China. We call it Mindre in Jordan. So please, Engineer Marianne, this will be a 15-minute talk.
هيك أحسن؟ Okay. Good afternoon, ladies and gentlemen. My name is Marianne Qasim. I'm the بس أنا عم بستنى هون الإشي يبين. إيش المشكلة عنا بالpresentation؟ طيب حاستغل اللحظات. Okay. So my name is Marianne Qasim. I'm the medical imaging business unit manager at Beta Drugstore. We represent Mindre in Jordan market, and at our business unit we have the ultrasound, X-ray systems, and liver fibrosis scan systems. Before I start my presentation, I'd like to take the chance and sincerely thank the president of the Jordanian Society for Obstetricians and Gynecologists, Dr. Abir Annab, for the efforts that have been done through the previous 3 years for spreading advanced knowledge, sharing experience and science. Your contribution and dedication is truly appreciated, dear Dr. Abir. Now, let's go to our presentation, which I'd rather call it an invitation than a presentation. It's an invitation for everyone to be part of setting the guidelines and rules of the practice of ultrasound shear wave elastography in obstetrics and gynecology. My presentation outline, I'll be talking about shear wave elastography, the technology introduction, and some Mindray features that makes it easier to use this technology, and possible use of shear wave elastography in obstetric and gynecology. Then we will have at the end like 1-minute live demonstration of Ulinker. Information that we get from the ultrasound. We get information for 2D anatomy images. That is, from the 2D, we get anatomy structure information. We get information for moving particles, and that is in color Doppler mode. For flow perfusion, we get this from contrast-enhanced ultrasound sonography. The answer for this question mark, what about tissue stiffness? Tissue stiffness information, we get this information from elastography features in ultrasound system. The principle of elastography is that when a certain force or stress is applied to tissues, because they are different in density and, for example, we have fat, we have bones, so the fatty tissues is squeezable more than the bones. So when certain force is applied, there's deformation in the tissue. This information of deformation is going back to the ultrasound probe and then is translated like this elastogram, elastography map on the ultrasound system. And it has indication. Here we have the hard in blue, soft tissue in red, and the middle in green. This feature, strain elastography, is a qualitative information about the stiffness of the tissue. Milestones in elastography. Elastography was first invented in early 90s. The obstacles, as I mentioned, it was qualitative only method, and it was used for superficial organs, like for breast, thyroid examinations. Then, in the year 2000, ultrasound shear wave elastography was invented, and it gave quantitative measurements, that is the Young's modulus elasticity coefficient, and it's measured in kilopascals, so we have some numbers. And you can use it for inner and deeper organs, like the liver, for example. In the year 2008 was the first ultrasound system that was introduced commercially to the market that has the shear wave elastography. So we're talking about a relatively recent feature in the market, 17 years only, and the most of the studies were done on the liver shear wave. Nowadays, liver shear wave is popular, and the liver fibrosis staging is popular because many clinical research was done on that. 2 years ago, the addition of viscoelastography was even added to this feature in order to examine the liver, for example, if the stiffness is coming from viscosity, from inflammation, or it's from the chronic liver diseases. The use of elastography and ultrasound. Here we have an image of breast ultrasound. Looking at the lesion, you can think it's a simple cyst lesion because it's well formed and like a black one. But applying the elastogram, it showed hard tissue. So maybe further investigations are needed. The use of it also in thyroid for investigating the lesions. These technologies, the purpose of it to make it as minimal invasive as possible, to make less biopsies for the patient. Another use, musculoskeletal, like this tendons. Sometimes when there's inflammation, the tendons are more stiff. In prostate, also the endocavity probes, you can use it for differentiating the lesions, malignant or benign. And this one is for shear wave for liver. If you see here, we have the quantitative measurements. The mean value is 6.5 kilopascals. After we get this value, we can go to the cutoff values and see that 6.5 is below 8 and more than 5.3, so the patient is diagnosed as stage F1 liver fibrosis. I'll go back to this slide to emphasize the features we have in Mindray ultrasound systems. We have the reliability index map, here the image on the left. This map, the color green, it shows that this area is reliable, so you can put your circle of measurement on it and avoid the less reliable area that is in purple. Purple, for example, here is on the hepatic veins, so you have to move away from this. Another indication, if you see the stars, the 4 stars on top of the image, these are the motion stability index. It gives you a guide that now it's stable to take the measurement. Now, the possible use of shear wave elastography in obstetrics and gynecology. During the last 2 weeks, I was reading studies and I went through some studies which were published recently in beginning of 2025 and 2024. Some of them was the placenta preeclampsia early diagnosis from using shear wave. A group of pregnant ladies were examined at the gestational age 16 to 20 weeks. The ones who developed preeclampsia shows higher values of Young's modulus versus the ones that didn't develop preeclampsia. This paragraph I got from the study. If you see 27.9 kilopascals versus 4.5, so the measurements were higher for the ladies who had preeclampsia. Predicting such conditions ahead could lead you to take the necessary precautions ahead of time. Another study was about sudden preterm labor production. When measuring the short cervix together with when examining the cervix elasticity using shear wave elastography, the internal os and external os of the cervix elasticity could give also a more precise and accurate indication, prediction about sudden preterm labor, so you can take the necessary precautions for this case. Like, for example, cyclogist might be one of your plan treating such cases. Other study was about polycystic ovaries disease diagnosis. Polycystic ovaries disease, there are too many follicles, so I think the too many follicles are making pressure on the tissue of the ovary, so the stiffness of the tissue is different and shows different readings than the normal ovaries. And the fibroid and lesions in general, the main purpose of elastography to differentiate the malignant, benign, and set the cutoff values when to get biopsies, when it's not necessary to get biopsies. Again, this feature is recent and the studies are recent. Cutoff values are not set yet. We will be honored if any one of you is interested to help us and be part of developing these features and cutoff values. If anyone is interested to run clinical research, please come contact us. Now, we will be having a look at our booth in next room, but please stay seated. We can do this using the U-Linker. U-Linker is a device, it looks like a mobile phone, and by U-Linker we can do live live exam streaming. Now we will be connected to our booth. Sorry, this is Fifi. We will be connected to our booth. Our colleague, Engineer Rula, is at the booth, and she is sharing with us the live ultrasound examination. Rula, I think I need to unmute just to hear you. Wait. Okay. Hi, Rula.
Hi, سامعني؟
Yes.
Hi.
Please show us the baby that you have.
مرحبا، مساء الخير. اوكي، انا حاليا في بيتا دراج ستور بوث في قاعة البوثات هون، وعم نعمل لايف ستريمينج على جهاز الريزونا اي 9 كونكتد مع اليو لينكر. كنا بس حابين نورجيكم فكرة اليو لينكر واللايف ستريمينج في مايند راي. حاليا عم نفحص ببيبي لايف. الفكرة انه كل الاوبشنز حتى بتبين اذا اخذنا بولس ويف، الكلر، اي حركة انا هلا بعملها على جهاز الالترا ساوند راح تكون مبينة برضه على اللايف ستريمينج، سواء اخذنا كلر او اخذنا بولس ويف او عملنا اي شيء من الميجرمنتس. ممكن انه كمان لو حطينا اي انوتيشن برضه راح تبين عندكم. وطبعا اليو لينكر او اللايف ستريمينج على المايكرو بلس هو تفاعلي، فممكن تشبكوه على الموبايل فونز لو اي حدا ينزل الابلكيشن بيقدر انه يفتح اللايف ستريمينج اللي انا هلا عاملته ويعمل اي انتر اكشن، سواء انه يعمل لي انوتيشن من عنده انا بقدر اشوفه عندي. اي حدا بيقدر مثلا انه يعمل ريمارك على اي جزء من الصوره برضه ببين عندي، وبقدر انه يعني تفاعل بالجهتين.
زي ما ذكرت رولا.
ذكرت مريان قبل شوي على موضوع الالاستوغرافي. ممكن انه احنا نجربه كمان عندنا على الجهاز حاليا. يعني رح احاول اصغر الريجن اوف انترست انها تكون على الانترست اتسلف. هذا بس تجريبي، طبعا بناء على القراءات اللي ممكن تطلع عنا، reliability index والقراءات اللي ممكن تكون موجوده، بناء عليه ممكن انه احنا نعرف الستفنس بالبلاسينتا او باليوترس. يعني الشرح اللي شرحت مريم بالاخر. واحنا هيك بس حبينا بصوره سريعه نورجيكم فكره اللايف ستريمينج، سواء انه احنا بنقدر نشارك فيها بالورك شوبس، ممكن تفيدنا بالمحاضرات، ممكن برضه بالاكزامز اذا كان في طبيب مثلا بده يعمل اكزام لاي حدا من الستودنتس، وعده مجالات احنا ممكن نستعمل هذا الاوبشن.
ثانك يو.
اذا في حدا حابب يسال اي سؤال او انه عنده اي استفسار تقدروا تمروا عنا بالبوث. اهلا.
طيب back to my presentation، بس عشان بحب أنا آخر سلايد. ليه هيك بصير؟ أوكي، آخر سلايد اللي هي صور المودلز تبعون الالترا ساوند اللي عندنا اياهم بمايند راي. و thank you so much for listening. حدا عنده أسئلة؟ تفضلي دكتورة.
It's actually not a question, it is a comment يا انجينير مريان. شكرا كثير، محاضرتك كثير حلوة. بس حبيت أعلق إنه في برشلونة جروب بيعملوا ستادي عن السيرفايكال إلاستوغرافي، وشغالة الستادي عندهم على أساس يعملوا موديل فور بريدكشن اوف بريتيرم ليبر. بس هذا اللي حبيت أعلق عليه. وحتى يعني بتمنى إنه حدا يعني من الأطباء هون يشارك في، يعني زي ما انت حكيت هيك، على الفايبرويدز، على السيرفايكال الاستوغرافي، بلكن احنا كمان نطلع بموديل اذا مجموعه كبيره من الاطباء خاصه في القطاع العام يمكن يكون عندهم بيشنتس اكثر يقدروا يعني يعملوا يشتركوا في الاستدي هاي.
احنا جاهزين. اللي مهتم احنا جاهزين.
يلا شكرا يا مريم.
شكرا كثير دكتوره. شكرا دكتور. شكرا جزيلا، يعطيكم الف عافيه.
شكرا جزيلا. It's been an entertaining morning. الآن بريك، lunch break. we'll reconvene على 2:15. 2:15 we'll start the next session. مش مهم مرة واحدة مكفي.